Thank you very much. Good morning, everyone. Finally, the third day, so I'm here to talk with you, to try to show you some of my perspective on spinal form and function, because this is what is about today. The first part of my lecture will be to introduce myself, because I think it's part of the lecture of the contents of the lecture, and all what I do about the spinal form function, leading to the second part, which is actually this recent paper published about this subject. So as I want to add more than what you said, but really just to make sure that as a physical therapist, being a researcher and a spinal researcher, it's really, I must be on both aspects as much as possible up to date about the information that is needed to be treating or to treat patients, and to the same time also to ask questions and go and make good research and publish it in order to understand how to do what I see in the clinic. So both aspects really has been the last 30 years my life. And this is like about really part of it. But I also say when you want to treat patients and treat pain, you have to be active and you have to care. That's why I'm privileged to be also very active in the youth of Arab in Israel. The one that we just recently came back from Korea within the competition, worldwide competition on robotics, and won the first place also. So it's all about treating patients, treating a healthy young youth in order to improve things. My lab, which is really concentrating on the spinal form function, it has to be really it has to deal with many aspects in order to understand or to let's say, try to analyze and describe and treat and diagnose the form and function. What's the relation between all these two? For example, if we talk about the spinal morphology and development, my PhD went actually in the States, where in Cleveland, where I was for 6 months almost, from 9 to 6 o'clock, clicking on a pedal just to measure vertebra of human being, thousands of vertebra, just to really know how this spine is built of this body. There's a huge collection there, the Hammond-Todd collection, and it's in a museum. Everyone was died about 100 years ago with all information, all medical information about it. So I really learned a lot about this. I'm going to talk about it in normal and pathological condition. So you have, for example, here you have the spondylolysis in the vertebra, but also I managed to, we're going to see later, about how the facet joint, how the vertebral body, how the neural arch is built, and there's a huge amount of important information concerning the asymmetry that is really there in normal situation, and how does it affect, or was it predictive for pathological condition in kids as long as others. And also just now finished a PhD student under my supervision about the thoracic cage development from year 1 to year 20 years old, to understand how does it develop, how it's related to all the respiratory system. You can't just go and treat the thoracic cage without really understanding how it goes on, what is the reasons that it's built this way, or is there any asymmetry, and such on and such on. We use a lot of CT MRIs to measure many aspects of the spine, either in the neck, thoracic, lumbar, and so on, to understand how it's going on. But we also go to the biomechanics and the imaging engineering way of building things. So this, as you see here, this model, for example, is a mathematical formula model that built spines. So it's amazing, because we gave CTs, and then the machine for about a week built on the form of the spine that is related to human beings in certain condition. And we managed to build this form, and then to ask the biomechanical aspect, how will it goes, or how will it act if we take off the ligaments, if there is a fracture, if there is spondylolysis, etc. This is like amazing biomechanical forces and kinematics that you can understand by understanding the form. And we also do a lot of to understand the kinematics, the acceleration, the range of motion of the lumbar spine at different position. We managed to publish 2 papers about that, about the rotational part of the movement during either erected spine or in a flexed position. So we have really continuing, but in the same way, talking about spinal form and function, we did and we're doing a lot of research on clinical protocols, on active exercises. For example, here's about the Pilates, but then about the rotational exercises and so on. A lot of protocols need to be checked, need to be examined to know whether it's good or not good, whether it's enough or not enough, whether we should combine or not combine protocols or exercise. We can't just say do exercise. What exercise? In which direction? How much? Which position? And so on. There's so many questions that the clinician and the researcher need to answer and understand how to deal with this spinal form function. And we need to think, we need to diagnose. So we have, of course, worked also on clinical reasoning and decision-making among physiotherapists, for example. And I want to tell you, there's a huge variability about the decision-making, and that really makes us try to improve our diagnostic and treatment tools in order to understand what's going on. And then we are doing also what is going on next, the next part of the lecture about the prediction. When you go and you do a surgery in your heart, you know, let's say, the percentage of success. You say 80%, 90%, or you take a pills, you know the success of Ecamol, if it's 90% improvement, so on. How much success do you predict from that in lumbar surgery? How do you tell it to the patient? We say, well, you got 70% or 80%. According to what? Is it according to objective characteristics, and also according to symptomatics? How do you say, as a surgeon, as a physiotherapist, what do you tell the patient? It's an amazing surgery. It's a huge surgery, especially if it really takes many consideration out. So when you ask about, when we check the spinal form, we can really try to understand what comes first, the egg or the chicken. For example, in spondylosis, we don't know what's the egg or the chicken, whether it was spondylosis in the years of 4, 5, or 6 years old. Do you know that it's 5, 6 years old? The spondylosis is there. About 46% of the kids. This is amazing. How does it affect their growth? How does it affect their function? And vice versa. When we find spondylosis in elderly patients, how did it affect the growth and development and the symptoms? Is it related? So we have an interactive model here to say that it's both ways. This can be answered only if you go and make a lot of research, a lot of questions to be answered. And of course, let's say, this brings me to my academic life, where we publish so many papers just to try to answer this question. And I have the privilege to be on both aspects, the clinician and the academic, and publishing many aspects of this question I just mentioned. I don't want to interrupt on one of them, but there's a lot of my publication about the spinal form in the beginning of my career, because I wanted to understand how the spine is how does it function according to its morphology. Because when you look at a CT or an MRI, you don't know really the normal aspect unless you see a pathological. But then you say, what's the normal? What's the normal variability of this lumbar, vertebra, facet, pedicle, and so on in the spine? So I really worked hard. We really worked hard to publish many of them. We managed to measure many aspects of all vertebra. I'm talking about thousands of vertebra. And we managed to find out amazing findings that were published really in a very highly level of journals. For example, the facet of the vertebra, the orientation, right and left, we saw that it is independent of gender, age, and ethnic group. That the thoracic facet, for example, are frontally oriented, whether the other one are less. So it's asymmetric. I'm talking about didactic, a very well-performed, well-built asymmetry in the thoracic facet on the left side compared to the right side, but it's not the case in the lumbar side. So you can see it here, when we managed to draw the orientation of the facet. It was really published in Spine at the beginning of my career. And you can see where it changes, why it changes, and you can make all the implications. It's the same with the facet tropism, which is called the asymmetry. How does it change What is it bigger on one side, less wider in the other side, and so on? And we can see that it is age independent. So nobody can say now that the facet in 20 years old is bigger or less, lower, or the one at 80 years old is smaller or bigger than the one, because it doesn't change. It doesn't change. The facet size or the orientation doesn't change. So anything to be or to change according to any pathology need to be considered in a different way. And of course, like I said before, it has interpretation, the kinematic interpretation. For example, if you have asymmetrical facet joint, right and left, if you have an asymmetrical one, then it may affect the rotation, for example, side flexion or inflection, because if it's asymmetric, then it's, of course, one is favored than the other. So the question is, well, if this is asymmetric, normal symmetric, there is many questions that need to be considered. The main implication is that any future development of the spinal implants should take into consideration the existence of facet or any other asymmetry related to the normal spine. You can't just put an implant to all of them, the same implants, without taking into consideration this aspect. So the existence of facet tropism actually raises the following question. Is the phenomenon of asymmetry in an inborn characteristic of the human spine, is it due to mechanical stresses? Is the consequences of existing spine deformity? Many questions. I can't answer them now all, but there's definitely a need to understand how the spine is built. For example, did you know that the spine is not really pyramidal in shape? We keep saying that pyramidal shape. It's not pyramidal shape. It's a trapezoidal aspect, and it shows many aspects of it. You can see it also. It's not alike. It's like an Ermite configuration. So it has a lot of trapezoidal shape, which is good for spinal mobility as well as spinal stability. And if we take this off and put an implant, just make it stable without thinking about this asymmetric, normal symmetric, then it may affect in the future the stresses over the disc. And that's why after a year or two, we have many recurrent bulging disc above the segment that was fixed, and so on and so on. So understanding the fall would really bring us to understand the surgery and whatever is needed. So we talk about low back pain. Of course, we know low back pain is so annoying issue around the world, and we know it's so costly, and we know that some patients follow the surgeon's advice with others choose not to do surgery. Who decides? I mean, if I come to we're going to say in the moment the paper that we published, two guys come to the committee with the doctors decide to do surgery for both of them. One decide not to do, and the other decide not to do. Who is right? Who is wrong? Why? What's the consequences whatsoever? So we have a lot of questions needed to be answered about that. This brings us to the second part, which is actually the clinical predicted or prediction rules for a specific kind of surgery for spinal stenosis. We talk about fusion. So if someone brings, and it's so everywhere, everyone does that, every country does that, so many. How can you predict? What are the successful parameters that you need to take into consideration before the surgery in order to understand how much success you're going to have with the surgeon? This is a big question. So in a way, we need to understand what does it mean clinical prediction rules. A clinical prediction rule is a clinical tool that quantifies the individual's contribution that various components of his history, his physical examination, basic laboratory results towards the diagnosis, prognosis, or response to treatment in an individual patient. This is what clinical prediction rule. These tools aim to facilitate clinical decision-making in the assessment and treatment of the individual patients, thought to be of greatest potential when they are developed and utilized for critical conditions that involve complex clinical decision-making. We're talking about complexity here. Low back pain is a common and costly complaint that has been specifically identified as an ideal target for CPRs due to its heterogeneous population and numerous treatment alternatives. Clinical trials have highlighted benefits of low back pain classification system that aim to match intervention according to the particular subgroup of patients. You need to know a subgroup of patients. You can't just say low back pain or spinal stenosis. Which kind, what level, and so on. The hierarchical process of rule developed is utilized, derivation of the rule, validation and investigation of clinical impact. All these aspects need to be checked when you do a prediction rule. You can't just say, I want to check. You have to really check all this. The derivations, CPR that have been derived but not yet validated are not considered ready for clinical use. CPRs may be unique to the study pollution or other characteristics of that clinical settings. So you need to try to learn from what has been done for many years and try to go and make it or suit to fit with what you want to do, or the other way around. Validation, the process of validation investigates a rule's performance and generalizability to other patient population, clinicians, and clinical settings. The validation of a CPR cannot be accomplished by a single study, but requires a process involving a series of studies that test the internal and external validity of the rule across a broad range of clinical environment. You have to check it, all this validity. The impact analysis is the process of CPR development that involves testing a rule's ability to positively influence clinical outcomes and change clinician behavior. Ideally, impact analysis involves a direct comparison to usual clinical care or judgment. And there's many studies that have been done. I won't, of course, talk about anyone, but this is what it's about. Go to the literature, understand what's happening, and try to build up. We know about the spinal stenosis now. That's the other aspect. The lumbar spine changes with the normal process of aging, may also undergo specific changes with pathological condition. The vertebral end plate, the upper and lower surface of the vertebral body, becomes thinner. Osteophytes may develop on the anterior rim and on the posterior rim of the vertebra after mid-age. A significant association between previous end plate damage and adjacent intervertebral disc degeneration has been demonstrated. As age advances, dehydration and deterioration of the nucleus proposes function and results in disc degradation. Degenerative changes in the intervertebral disc evaluated by MRI have also been found in asymptomatic people. Do you know, for example, here, if I just make an assumption, what's the percentage of people that are not suffering from back pain that have already a bulge disc? Would you say that? Sorry? 75. Sorry? 75. Well, okay, he's really going to that top, but I'm talking about at least half of the people here. It's about 40%, 50%, depends on the population. But can you imagine that you have a bulge disc and not symptoms? You're not symptomatic? So the correlation needs to be checked. But what does it mean, 40%, 50%? The fact that I've looked at the MRI, see if there is a bulge disc or not, that's not enough. That's not a resolution of morphologic analysis. It's not enough. This is why the assumption of this percentage is because I look at the whole about it, if there is or not any herniated disc. The reality is that there is so many microscopic changes inside that you do not follow, but are the reasons, some of them, and we have checked it and we have published it about several lower pain, non-specific lower pain, finding a specific morphological changes. So it's not about looking at the MRI, say there is or not, and here it is, the publication, and everybody talks about it. This is a misleading understanding the results about that. Sorry? Yeah, but it's not about if it's there or not. There's specific, I want to go because this is not the topic of my lecture. But if you go on really, for example, the orientation, just the facet tropism, nobody checks it, really, unless we use the AI in the future. And this is what I really go through it, to say, to give the information, to let the AI check, of course, develop it, and then you can have a single individual morphological characterization of the spine and its possible prediction for such and such. So we need to go forward. We need to run towards the development of these things in order to understand what's going on. The percentage of spinal fluid of the L5. The percentage? Yes. There is a different kind of spinal fluid. You're talking about the on. I don't remember the percentage, but 2%, 1%? 20%. And there's different kinds, different levels. So of the non-asymptomatic one. So there's different one. Okay, I can argue with that later, but all right. Okay, so if you talk about lumbar spinal stenosis, should not be offered for patients with no specific lower pain any surgery at this stage. Just don't say, oh, you have lower pain, let's go into surgery. No, no. The second thing, lack of consensus between 62 surgeons regarding both prognostic factors and predictive tests. I don't want to talk about the billions of dollars, okay, because it's very, very clear. It costs us a lot of money, and there is a broad heterogeneity of patients undergoing this fusion. So we really need to try to raise the question and see. Better preoperative walking capacity predicted better postoperative capacity and better satisfaction. Okay, did you ask the patient how much you work? Do you send the patient for a whole checklist characterization by a physical therapist? I suggest a physical therapist because I know it's a physical and symptoms. We're going to check it out. Do you send him for a whole checkout and come with this protocol and see what's happening with him so we can actually compare it then and predict? No, we should do it. Exactly based on the depression predicted, more pain, 6 months follow-up, worse symptom severity, less treatment satisfaction, and poorer walking capacity. My God, it's not about fusion. It's a human being, as you said, Dr. Ryan. Better, safe, rated health, and higher income both predicted less severe symptoms, better walking capacity, and treatment satisfaction. Greater cardiovascular comorbidity was a negative predictor. So we need to know these things before starting this surgery. The morphological, I won't talk more than that because I just mentioned it. And of course, the prediction. So patients with chronic lower pain and neurological symptoms are often given the recommendation to undergo lumbar surgery. We agree about that. This is what happens with them. Some patients follow surgeon advice, whereas others choose to avoid surgery. It's a reality. We know that. Today, the indication for lumbar surgery includes level of disability, history, and morphological findings. The question remains whether the patient screening process before the accommodation of surgery can be more accurate. Of course, the answer is yes, after all this. Okay, so the included for this study, specifically for this paper, men or women 40 to 8 years, unstable degenerative spondylolisthesis, radicular pain or stenosis with referred pain, exclusion, psychiatric illness, and so on, all is written. We need to really try to be sure that are not related to other conditions rather than the spine. Of course, as we have been mentioned here the last 2 days, we use the International Classification of Functional Disability. Of course, it's like the ICF framework. We know it's there, but we need, of course, to translate each one for the one that we want to check. For example, the health condition is about the disc herniation, spinal stenosis, modic change. I don't want to talk about it. There's a lot of things to know. The impairment in body structure. It's about the mid-disc height and transfer, for example, interface angle. We really want to check specific things for these categories. Body function, range of motion, strength, for example, activity and limitation, gait, balance, participation restriction, activities of daily living, etc. and so on. So we want to know if this can be predictors, patients suffering from chronic lower pain and leg symptoms following decompression, fusion lumbar surgery, or non-surgical things. The method, we divided into surgical and wait-and-see groups because they both came to the committee and they have the decision made already by the doctors that you need surgery, following all other aspects they have been doing already. So it's decided both that they need surgery. If they say yes, they're going to be cut. That's it. So we actually divided into two. There was a physiotherapist, he's a doctor now, Dr. Soroka, my student, previous PhD student. He sat down in the committee and for months, for about 2 years, he was managing to hold, and there was different COVID and also around the area. So we had to hold to know what's happening with everyone. And we managed to divide it to T0 baseline after 3 months after, 6 months and 12 months. We gave questionnaires and functional tests by each side, but then at 6 months, only the questionnaires to be held. The self-report measurements, as you see, the ODI, the Ronald Morris, the Burmouth, the Fear Avoidance Belief Questionnaire, International Physical Activity Questionnaire, and numeric range. A lot of questions to be asked, to be checked, to be examined, because this is what shows us what's happening with this guy. And of course, the ODI, we know it's about standing. I won't go through this, but it's really to understand what's happening with this guy when he's standing, when he stands. The same thing with the fear avoidance beliefs questionnaire. It's a physical activity subscale, work subscale, and so on and so on. The Roland Morris, very well known, yes or no, about 24 questions, and the Bournemouth, to what extent were you able to control, relieve your back pain on your own during the past week? So I want to know what's happening with you, and functional parameters. A lot of physical examination in the first two sets. As you see here, we have passive SLR, chair, sit and reach, chair, sit to stand, grip strength, heel rise, lunge descent or corridor walk, single leg distance, 8 foot up and go test, 4 square steps, many examination. So if you take this to any patient to go to the physiotherapist with this list and check it and write it down, how much is achievement, you might just really understand or learn what's a success. Morphological condition, and this is the baseline, of course, the results. We got about, of course, 31 and 77. Of course, the one with the surgery is more than the one with the baseline with the wait and see, because it's much easier to go, oh, let's go, the doctor had decided. So we have this flow chart, and we got the answers. Well, I can tell you that in the beginning of this condition, there's almost no difference. There's no significant difference here between the wait and see, the blue, and the surgical group. So the two, and this is good, because if you don't have many differences objectively, then you might say, okay, this is the same group, except for the walking distance and pain in the symptoms in the legs. Yeah, in the legs. So when we looked about that, the self-reported measurements the same, but you can see that the baseline, there was a difference there, but it's not significant as much, but then goes together between surgery, between the surgery and we can see 3 months after the surgery. So let's say after 3 months, sometimes the surgery goes back because of the surgery, of the pain and limitation and so on. So there's different aspects that can be changed, but the answer is it's all also with the Borman, no difference at all, except for the fact that such. Okay. You can see there is no correlation, as the literature have shown, between the morphology, a specific issue here, but morphology and ODI score. So it's not really correlated how much change you got as much as how much dysfunction you got. We can see the green light, the green color is a good change. Okay, let's go this way. It's a good color, but this is about the surgery. How much? For example, the more you sit before surgery or before the way you see, the less improvement you got. The more you walk distance, the better improvement you want. So these things I need to know. How is, you can't just say I walk. How much you walk, when the pain is there, and so on and so on. So this model, this package, explains the model overall explains 30% of the variation in ODI change. This is really important because we can't just take one aspect and say, oh, if you do that, then you understand everything. No, you must have all aspects, and then you understand that it explains 30% of the change. Okay. I don't know why, but this happened. Okay, so if I summarize this part, the wait and see group presented a better functional status on, let's see, on the baseline. Most functional differences remain during the 2-4 months follow-up. In the short term, the surgery helped participants to improve in reducing back and leg pain, ODI and so on. Despite the differences in the baseline function between groups, no relationship was found between the ODI difference over a year and the morphological measurements. Given the fact that the wait and see presented better baseline data and even maintained the results throughout the year, the questionnaires and tests they performed should be taken into account in order to complete the decision-making process for the surgery candidate. What does it say? That the patient were right not to do surgery. They decided upon themselves not to do surgery, and they were right, according to all these tests and questionnaire. They were better baseline than the one that decided to do the surgery. Our findings support the existing gap, of course, between the structural and clinical findings and strengthen the connection to the set of different components. While surgery predicted a greater improvement, both groups ended up with the same ODI score. People who were sitting more tended to improve less. People who were sitting more tended to improve less, supporting the importance of movement in the recovery process. What do we say to the guy who do surgery about 3 months after surgery? Not to sit, usually. Why? Is it really, are you sure about that? Sorry. Are you sure I'm going to give this instruction to all people the same? Is it right to do the same? So this kind of movement or not need to be investigated. Sorry about this. Interestingly, people with better walking ability and flexibility improve less. While this suggests that they had less room to improve, these findings need to be further investigated. And here we go. The chair, sit, and reach test appears to be more relevant to participant success than the commonly used straight leg raise. So use this. The chair, sit, and reach test is an important predictive objective examination to do. How much do you do it before surgery? We do this a lot. We do it. How much do you do these things? This simple combined and available test may provide a broader understanding of the patient's ability and disability beyond the morphological findings and pain. For the clinicians, understanding the full range of candidate characteristics pre-surgery will reflect the ability of physical and psychological coping in lumbar surgery. Future studies should consider investigating further improvement with an organized plan for physical activity and rehabilitation, which would benefit the surgical group. Our prediction model can be a preliminary basis for development of CPR for lumbar surgery. So we published this with a proof conclusion that functional status, self-reported disability, and fear avoidance beliefs in lumbar spinal stenosis patients reflect their subjective decision regarding surgery and highlight the importance of baseline leg pain, calf strength, walking-related parameters, and physical function in recovery. Well, there is one thing that was missed. We didn't talk about it because we published previous paper. I just say 1 or 2 slides about it. It's a follow-up risk. What's a fall risk? The question raised whether low back pain is related to increased fall risk. Marshall found that back was independently associated with increased fall. They suggested that it should be examined or not. But of course, back pain intervention reduced fall risk in this population. We did this part. We compared to the American population with 30 patients with the NYU, and we did the same research, but on the balance aspect, and we managed to publish it with whether balanced performance at baseline predicts long-term surgical outcome. We can see that balance and fall risk before and after lumbar surgery was assessed to determine whether balance at baseline predicts long-term post-surgical outcome. I don't want to say about this. The methods, 40 patients here, 43, and so on. We did the same measurement, but we did the balance test specifically to understand it, to answer these questions, a very important question, and we'll go the result from baseline to follow-up. The select of time was, well, I'm just going to go because I have not enough time now. I'm going to the conclusions. Risk of falling is higher than surgeons suspect. Balance tests, like those that I mentioned, are quick and easy to administer. They find support the importance of screening for balance and fall risk in adults undergoing lumbar spine surgery. Thank you for my beloved city, Jaffa. In really one of 5,000 years ago, there was a city being established called Jaffa, and I'm privileged to have all my grandfathers from this country. Thank you very much.